Welcome to this clinical breakdown on differentiating idiopathic Parkinson's disease from drug-induced Parkinsonism. This is a vital distinction for us in clinical practice, especially when managing patients on psychotropic or gastrointestinal medications. Let's compare these two entities across several key clinical domains. First, consider the onset of symptoms. Parkinson's disease has an insidious, gradual, and progressive onset that unfolds over years. In contrast, drug-induced Parkinsonism typically presents with an acute or subacute onset, usually developing within weeks to months following the initiation of an offending drug or a recent dose increase. Next, look at symptom symmetry. Parkinson's disease classically begins asymmetrically, starting on one side of the body before eventually becoming bilateral. Drug-induced Parkinsonism, however, is often symmetrical right from the onset. When evaluating tremor, a classic pill-rolling resting tremor is very common in Parkinson's disease alongside the other core features of bradykinesia and rigidity. In drug-induced cases, a true resting tremor is much less common. Instead, you might observe action or postural tremors, and it is crucial to monitor for concurrent extrapyramidal symptoms like akathisia or dystonia, which strongly point toward a medication-induced etiology. The progression of these conditions also differs significantly. Parkinson's disease is chronically and relentlessly progressive. Drug-induced Parkinsonism tends to remain static as long as the medication dose is stable, and symptoms will typically improve or completely resolve after the offending drug is slowly discontinued. Regarding treatment response, patients with Parkinson's disease will demonstrate a robust and sustained clinical improvement with levodopa therapy. Patients with drug-induced Parkinsonism will generally have a minimal or entirely poor response to levodopa, as their dopamine receptors are already blocked. The underlying causes are fundamentally different. Parkinson's disease is neurodegenerative and largely idiopathic, though influenced by genetic and environmental factors. Drug-induced Parkinsonism is secondary to dopamine-blocking agents. As residents, you must maintain a high index of suspicion with first- and second-generation antipsychotics such as haloperidol and risperidone, antiemetics like metoclopramide, and certain calcium channel blockers. Do not forget to assess for prodromal and non-motor symptoms. Features like hyposmia, rapid eye movement sleep behavior disorder, severe constipation, and depression are common early indicators of Parkinson's disease. These specific non-motor features are typically absent or significantly less prominent in drug-induced cases. Finally, if diagnostic uncertainty remains after a thorough clinical history and examination, functional imaging can be utilized. A DaTSCAN will be abnormal in Parkinson's disease, showing decreased and asymmetrical dopamine transporter uptake due to underlying neurodegeneration. In drug-induced Parkinsonism, the DaTSCAN will be completely normal, reflecting preserved presynaptic dopamine transporter function despite the postsynaptic blockade. Keep these crucial differences in mind during your evaluations to ensure accurate diagnoses and appropriate medication management.